Welcome, everyone. We are so excited to have Dr. Nadine Levick here. Nadine, thanks again for joining us at the EMS Leadership Summit.
Real pleasure to be here. From the other side of the world, I'm sitting here 16 miles from the Gaza Strip, working at a bomb-proof hospital, the first hospital built in Israel in 40 years, and designed to meet some of the pressures of emergency medical services here in Israel in the south.
Well,
today I'm going to be sharing with you some thoughts on safety and design innovation in emergency medical services, and try and get a bit of a glimpse of the cutting edge. Leadership is where innovation is going to be deployed, and very keen to bring to the table some of the concepts and principles we've been looking at over the last few years.
Nadine, I'd just love to give some of our people watching just a quick intro to you, because for those of you that may not know out there, Dr. Levick has an extensive history in EMS safety and really a pioneer when it comes to ambulance safety, from the first ambulance crash testing, rollover crash testing, forming the EMS Safety Foundation.org, also known as Objective Safety, as an open source portal. Dr. Levick has been awarded over $3 million in research funding, and she's published more than 27 different papers in numerous books in numerous journals. And coming originally from the Royal Melbourne Hospital and the Royal Flying Doctor Service in Australia, one of the first, I believe, board certified emergency physicians in Australia, and landing in Johns Hopkins, and then spending over 20 years at Columbia University. Again, just to give some people a quick background on who you are. And again, we couldn't be more thankful that you're able to join us from Israel now. So thanks again for joining us.
That's a pleasure. So what I'm going to walk us all through is a bit of a snapshot of innovation in emergency medical services safety. And we're actually not going to be talking about clinical procedures. It's going to be a focus on system safety and strong emphasis on transportation. Because if you take a look at where all our risk management fails us, where are the problems that the insurers are paying out for? It's not medical error, it's transportation adverse events. We're going to look at what's out there to enhance our ability to optimize the system safety and to look at design innovation. A lot of the information I'm going to share today has been work that's been done under the umbrella of the EMS Safety Foundation by largely our innovation consortium over the past 10 years now. We're in the 11th year now of the EMS Safety Foundation, and also some of the work many folks have helped with under the umbrella of the National Academies of Science, Medicine and Engineering, where I've been the chair of the Transportation Research Board's EMS Safety Subcommittee now for some years. So let's just start with what's safety. Well, really, it's a condition of being protected against either undergoing or causing harm, injury or loss. And what's design? Well, it's developing something with intent and purpose that is a solution that embodies functional and to some degree also aesthetic demands. And what's innovation? Well, here I am in Israel, a country the size of Lake Michigan, with a population of 9 million people, that has developed technologies that are used globally, and one of them we're going to be touching on briefly, or maybe two. And really, it's a huge innovation hub here. So what is innovation? Well, it's something new and original and more effective, and that's where the rubber really meets the road. So I'm going to speak briefly on some historical perspectives, some key determinants, open source issues and aspects of what's out there, innovation dimensions, some challenges that we face, and I'm really going to wrap up with, it's actually now, because of a lot of these opportunities that are available to us, cheaper, better and safer. So this is not how to spend more money on having a safer system. This is how to leverage existing technologies to have a better, safer system for less. So when it comes to EMS design, and risk. As I mentioned right at the start, the medicine piece is really important, but we do that really well. It's the transport piece that, most of us who are working in some aspect of EMS are medically trained. We're not necessarily transport trained, and we're going to look at how that interface falls out. And as I mentioned, it's the transport aspect that carries most of our risk and hazard. And I think the really key issue that embraces everything I'm going to talk about today, and pretty much everything I talk about every time I speak, is that ambulance transport safety is part of a system. And the overall balance of risk in that system involves the safety of all the occupants in your EMS system and vehicles, providers, patients, family members, and also the safety of the public. And it's a very different paradigm to what we see in the hospital system. So how does EMS design happen? Like, what goes into designing your EMS system, operations, vehicles, equipment, clothing, everything? Tradition in the United States is a huge driver. Experience, sure. Vision, less often, and really embracing our interdisciplinary colleagues, even less often. And, how many times have I heard, but we've always done it that way? And, that way may not have been the best way. So really, I see the frontier of EMS safety right now, that interface of disruptive new technologies, including open source technologies, and our operational practice at all levels of the EMS system and across discipline. Gartner's hype cycle has a few different stages in it. The innovation trigger, the peak of inflated expectations, the trough of disillusionment, and the slope of enlightenment, and the plateau of productivity. And it's no surprise that what I'm going to be talking about is not what everyone's sort of focused on and dealing with right now, but it's what some of the innovators are dealing with. It's autonomous vehicles, commercial and unmanned drones, augmented reality, virtual reality, as well as artificial intelligence. And, it's a different world. We're really in a different world. In the 1980s, some of us may remember that brick thing and have been really impressed with it. But now we've got an Apple Watch and it's got far more capacity and it's a fraction of the size. But if we look at EMS, particularly in the United States, in the 1980s, that's what we had. And this is what we have now in just about most EMS systems, well over 90% of them. Safety in EMS is multidisciplinary. It's clinical practice, public health, automotive safety, impact biomechanics, human factors and fleet safety, and everything that goes into fleet safety, from the hours of service, the oversight of the system safety, to the vehicles themselves. Really complex. Transport safety is really complex. There's many elements that come into it that are really not our core expertise areas, such as ergonomic research and other elements like, sorting out safety technologies, epidemiological data collection, and even biomechanics and automotive safety. There's a great quote from Joe Borgraf, who's the president of the Furno Group, and I want to bring it in here. And he states, to create an innovative and model EMS system, we must engage in a collaborative and cross-functional conversation among the many contributing partners in the EMS industry. Even the EMS suppliers should embrace and drive new innovation so that we can aim to improve the process and efficiency of delivering our service, while advancing the level and outcome of emergency care. And I think that really does sum up what we're grappling with here. There's lots of ways of looking at a safe system. This is actually a standard outline of approaching transportation safety. And the core of that is human tolerance to physical force and all sorts of other elements that engage optimizing safety. Then we have the Vision Zero, a conscious decision to eliminate death and serious injuries, and how to go about doing that. And if there was ever a system that should be eliminating death and serious injuries in the transportation component, it should be EMS. We touched on it right at the start, that the safety of the provider and the public and the patient are all elements in the safety of the system. And, in our healthcare system in the hospitals, the focus that we have very much is patient safety. And there's been a lot of focus in EMS also on patient safety. But really, when you look at the priorities, we're in a transportation environment in EMS. And the provider actually got into that vehicle that day healthy and well, usually, and the public driving around on the road are healthy and well. So that pyramid with the patient at the top is a little different when it comes to EMS. And really, the provider and the public take a priority over the overview of safety. You can't be running a red light with a patient who may be in cardiac arrest and not have a good potential outcome and end up doing something that results in the death of a member of the public and a provider. And safety is there as a tool to save lives, time and money, but it better be evidence-based. If you've got a supposed safety intervention and there isn't independent evidence that safety intervention's going to actually make a difference, you don't want to be spending money on it. It may not make a difference. So when it comes to transportation safety, there's sort of three main realms. There's impact biomechanics. It's how your vehicle operates should an impact occur, should there be a crash. It's how can you do your work in a transport setting, and what work should you be doing in a transport setting that's going to make a difference and also keep you safe. And how do you keep your fleet safe? What data do you capture? What do you look at? What are the metrics that are going to make a difference? I mean, you can look at all sorts of metrics, but what are the metrics that are going to give you a good benchmark of what is the safety of your system? And a lot of what we see when we start to look at when things go wrong is predictable, much of it preventable, and very seldom is it actually an accident. Ambulance design. Technical science, well, yeah, but not really a new issue. Greater than 150 years ago, here's a patent that was submitted to optimise the transport safety in an ambulance. I think that was a buggy with a horse back then, but improvement in ambulances, there you go. W. Arnold from West Virginia. And that's the sort of vehicle he was trying to improve. And if you were to survey people for what would enhance safety and efficiency back then, okay, people would say, well, maybe more rest stations for the horses, or maybe more horses. But they wouldn't have said the combustion engine. And that's when we start to survey people for safety innovation, we're maybe denying ourselves the real core of what innovation is. And that is what we talked about right at the start. So let's have a little look at our more recent timeline. Back in the 60s and 70s, we didn't really know that EMS safety was an issue. We all happily got blood on our hands. I myself remember being an emergency physician and sort of saying, oh, I don't really think I need to wear gloves because I can't feel the vein with my fingers. I thought, well, you should see me now. Sometimes I put on 2 layers of gloves, depending on what I'm dealing with. And then 80s and 90s, we sort of knew it was an issue, but we sort of really didn't have a blueprint of what is it that we've got to do to optimize safety. Let's look at the last 10, 15 years. We really have a lot of technical safety data. It's been rolling out. And really the challenge that we have now is how do we change what we do? How do we adopt these new technologies that can optimize the safety of our system? Lots of things we know about. safe systems, crew resource management, transport system safety, risk perception, fleet operations management, vehicle design safety, scene safety, patient handling, health and wellness, hours of service. They're all out there. And we can go to resources such as ems.gov and hear about some of these concepts. But when it comes down to what oversight is there of the safety of the system, we have challenges in identifying best practice. We still have a myriad of unregulated commercial products that may be a solution to a problem that might not exist. We don't really have true system safety performance standards, and we remain absent of national safety oversight of our transportation performance. The Federal Motor Carrier Safety Administration ensures the safety of federal motor carrier vehicles, but we're not included under the umbrella of the Federal Motor Carrier Safety Administration. Actually, in the United States, there are more safety standards for moving cattle than there are for moving patients. And the laws of physics prevail no matter what we do or what we say. We can't deny the facts that a lot of this is totally predictable and much of it preventable. We at least have some information, but in the absence of a true data capture system for EMS safety performance, government estimates are always going to understate the situation, as bad as it may look. 84% of providers were unrestrained in the setting of injuries. Patients are not always secured with shoulder and lap belts. And as I said, these data are an underestimate. And of course, medics are not wearing their seatbelts because there's challenging design-related human factors issues. You can't reach your equipment without standing up and leaning over in a moving vehicle. I mean, why should you have your equipment on the other side of the patient, where you can't reach it without standing up and exposing yourself to ergonomic challenges, automotive safety challenges, biohazard challenges? The interior designs of our ambulances expose EMS providers and patients to significant automotive, ergonomic, and biohazards, obviously seen in these simple photographs. But there is a science of safety design. This is a frequency analysis showing some of the different items that can be identified as easy to reach, less frequently reached, and all laid out based on what science says. What is it you need to reach for when? Let's position it so you can get to it without having to remove a seatbelt or get out of a seat. So there's science behind these practices. We can test the real world, and this is a bit of a historical photo of one of the world's first ambulance vehicle-to-vehicle crash tests that we conducted when I was at Johns Hopkins. So really, our focus is to work smarter, not harder. We can learn from our international colleagues, and here's a couple of the leaders of emergency medical services over the last really 20 years in the United States, AJ Heitman and Scott Cravens, who's meeting with Professor Sefrin at Germany's Repmobile event, where we learn about a lot of things. We can see the old, expensive and non-versatile technologies, or the rapidly changing, much more cost-effective, cheaper, better and safer versatile technologies. And we're starting to see the transition towards the utility of these sorts of technologies. Design layout that makes sense. It's based on what it is you need to do in EMS and to keep yourself and your patient in a safe environment, with you having access to what it is you need to access to care for the patient without having to actually be walking around in a moving vehicle. And we saw quite a few examples of this in our trips to Repmobile with the EMS Safety Foundation, where everything was designed around you not having to reach across a patient or stand up to get to what you need. So there's lots of new aspects to vehicle design, vehicles that are smarter, sleeker, safer, and of course, cheaper. operations, new technology tools we're going to touch on, and lots more opportunities, such as this very one you're listening to, this Leadership Summit, to really get to hear what's out there and to challenge the status quo of tradition and experience, and to look at what is out there from the interdisciplinary platform to optimize the safety of your performance. There's one small project we've embarked on with the EMS Safety Foundation, and that's our in-demo unit that you may well have seen over the last couple of years, actually last 5 years, at some of the EMS shows. And this is just a physical setup, so you can actually get inside a demonstration environment and see how different it is to be in this sort of setup compared to the setup that you're used to and that you know. And simple things like bags hanging off the wall, seats that not only slide backwards and forwards but slide close to the patient so that you can actually provide the care you need to provide. And configurable, you can move bits in and out, move the seats backwards and forwards on the track, put in 2 stretchers if you like. These are not new technologies. It's just an application of existing technologies. All of us have been in aircraft. The seats can be moved close together, further apart. They have the same sorts of tracking systems. I'm going to talk a little bit about the integration of some of these new technologies, fleet management tools, the vehicle design issues we've just touched on, a few words about the visibility, the cloud, the crowd, artificial intelligence, augmented reality and virtual reality. Telematics. Okay, so how much technology and data and of what type do you need to improve your fleet safety performance? Fleet telematics tools. There's a number of them out there, and trying to determine how much data you want to collect and on what to properly support your decision making and oversight of the safety of your fleet. There's numerous of them out there. I'm not going to go through all the ones that you can access, and there's new ones popping up all the time. So really, you know, next is now where we're now looking at fleet mix, which isn't only, is it a bicycle? Is it a Segway? Is it a little golf cart? We're looking at drones. We're looking at vertical takeoff vehicles. We're looking at voice-activated commands, mixed reality, as I just mentioned, and we're going to touch on in a little more detail. Some advanced smartphone technologies, connected health, wireless patient monitoring, and health information exchange applications. You know, fleet mix used to be this: Segway, a motorcycle, sort of golf cart, gator, a bicycle, and still remains cutting edge in many areas. Motorcycle medics are out and about. Here in Israel, we have a number of motorcycle medic units, Magen David Adom and also Hatzalah being the first to have a fleet of motorcycles. But many places around the world, motorcycles are being deployed as cost-effective rapid response units. Virtual reality. Well, if you have a look down here, you'll see it's all pretty recent. Most of the virtual reality first aid in EMS has popped up in the last year and a half. Virtual reality patients in EMS, we can now train on virtual reality and do simulations. We can do CPR and first aid training as they've done in the UK. In Australia, in Victoria, they're actually doing virtual reality training in EMS for violence training. And here they are having a class of violence prevention with virtual reality goggles. This is a very impressive system. Actually, also out of Australia, Real Response. These guys are doing virtual reality mass casualty disaster management, and it's a great way to train people. And here you can see Neil Blackington from Boston EMS. We're actually in Dubai there, and he's having a look at some of the virtual reality tools for mass casualty disaster training there. And, you know, these are great tools and really should be being deployed in every service. They're cheap, they're cost effective, you can train more people more quickly and evaluate them well. There's even virtual reality tools that we've been looking at that will help you design the interior of an ambulance, so you can just pop on the goggles and look at a few different interior design approaches. So AI and EMS dispatch, well, there are now some AI modules looking at detecting cardiac arrest by the nature of the breathing that they can hear down the phone. And some of these AI algorithms are actually showing themselves to be more efficient at detecting cardiac arrest and more rapid at detecting cardiac arrest than a well-trained person. So we're starting to see these being piloted around the world. And here's another application for Dubai Ambulance, Dubai 10X, looking at AI being deployed in their ambulance system. We also had an opportunity to hear about some of the work being done at South Metro Fire and Rescue, the health information applications for emergency services, where they're looking at some of the AI applicable approaches to optimizing their system dispatch. And of course, we're in the realm of wearable tech, and we're really in a situation now where most of the vital signs that we captured can be captured wirelessly now, with all sorts of different products that are out there in the market, that being one of them. Probably one of the more innovative, and I touched on this project at the start. Waze is actually a platform we're all very familiar with. I think most of us are very, very glad that Waze exists. I can assure you, in Israel, it's a great tool. In actual fact, it was developed in Israel. And this is a great project here, Genesis Pulse, that is integrating Waze with your CAD. So now you're integrating the crowd and the cloud with your CAD dispatch. And very impressive to see that operational. Clearly not something we could have even dreamt of even 5 years ago. We're also starting to see unmanned ambulance drones delivering primarily at the moment defibrillators and a few other emergency health service tools, such as in some areas also delivering blood. And the future is opening up for manned drones. And this is one example in development of a manned drone that is being looked at for an application to the EMS environment. And here's another that made its debut at the Consumer Electronics Show last year. And again, driven by an iPad, although you won't see me getting anything driven by an iPad anytime soon. So I just want to wrap up. We've touched on a number of areas of innovation and design to optimize safety, and just to take home is that ambulance transport safety is part of a system, and the overall balance of, just got to listen out for those sirens here in Ashdod. As I mentioned, we're only like 16 miles from Gaza, and I've got like 45 seconds to get into my bomb room. But the ambulance transport safety is part of a system, and the overall balance of risk involves the safety of all the occupants and the public. Look, things can go wrong, and I happened to be in New York the day this happened, and when you've got sound safety policies and technologies in place and a system is well prepared, you can minimize harm. So, big take home, we are not the experts technically in safety science. We're the experts in emergency medical services. We can't afford to play the silo game here. It costs us lives, time, and money. We must have a meaningful evidence-based approach to design, operations, and policy, and it must be outcomes driven. So just to wrap up, there have been major advances in EMS safety research, new technologies, infrastructure, and practice, particularly over the last 5 years. Safety just has to be inherent to operational process design. It can't be an add-on. It's got to be part of that system. And understanding that really complex interplay between patient, provider, and public safety from a systems perspective is key to make sure you've got an effective, safe, and operational EMS performance. We've got to make sure we engage those experts outside of EMS from systems design, transportation safety, human factors, and safety analysis. And we need to have safety performance standards. We need to be benchmarking just like we do for the rest of our commercial fleets. And we need to keep in mind that we are still way behind the state of the art in vehicle safety, occupant protection, and fleet management. than the rest of the fleets on the road. So there is a handout electronically. You can scan the QR code or go to that link. I should have that posted for you shortly. So I think we're sort of done.
So we'd love to hear a little bit about your crowdsourcing application for crowdsourcing AED locations as maybe a national AED registry or a regional AED registry.
Right. Well, one of the things, I suppose, being an ER doc, and I know, and cardiac arrest is not usually successfully managed in the emergency department, but it's really a community issue, and rapid access to public access to fibrillation and CPR is going to make the only really substantial increase in survival. So I'm going to just cover a little bit about our rescue project. It's in development at the moment. As a matter of fact, having just moved to Israel, somewhat, let's say, unexpectedly, to come over here and take this position in research and innovation. But we actually had just submitted our first NIH proposal on this project, literally as I was about to leave the United States. And so we're looking at doing our initial pilots here in Israel rather than in Staten Island, which is where we'd planned to do that. But in 6 bullets, it's social good, it's crowdsourcing, community engagement, it's mapping, it's augmented open government data, it's public health and safety, and it's saving lives. In the United States, every day, greater than 1,000 people die outside the hospital of sudden cardiac arrest. It's 10 times annual road deaths in the USA, and it's 10 times the annual gun deaths. It's about 380,000 men, women and children dying every year in the streets, workplaces and playgrounds of our homes and communities. Would you be okay about 3 jumbo jets crashing every day? 7.5 full Yankee stadiums of deaths every year. It's very difficult to quantify a big number like that, all dying from sudden cardiac arrest. And what is it? We all know heart doesn't pump effectively and you're dead in minutes. And often we know EMS just can't be there in time. And the death rates are really high, depending on where you are. Some places survival is better. New York and Detroit, New York, where I was based for 17 years, has very low survival rates, and many different elements play into that. And whether it's vertical elevation, traffic congestion, the psyche of New Yorkers, all sorts of things. But it's not like on TV. In most environments, survival is low. And in most environments, there are areas where there's high performance outcomes, but they're not necessarily areas that are easily replicatable. There's a lot of infrastructure that goes into those environments where cardiac arrest survival is high. And you can look at Copenhagen, you can look at some isolated areas in the United States, and whilst they're fantastic models, they may not be duplicatable and replicatable. But we do have the tools to manage cardiac arrest. They're just seldom used. And really it's bystander intervention with CPR and AED use. And, people have 3 simple things to do: call 911, do CPR, and find and use the nearest AED. And that's wherein lies the challenge. One, many people in the community don't know what an AED is. They don't realise it's for lay people to use. Some of our software developers, when we first engaged them, said, well, I'm not meant to touch that. It's got that lightning bolt on it. That's a danger symbol. And then if you manage to get past educating them what it is and that it's for them to use, how do you find it? So some of the statistics show that up to 80% of victims could benefit from the use of an AED in the setting of VF arrest, but it's only used in less than 2%. And really all the public need to do is grab one, turn it on, and it'll tell you what to do. But how do you know where the nearest AED is? And what do you do when there's a database that you need to save lives and you don't have it? And you're told it's too expensive to build and maintain. Well, It comes as quite a surprise to the public. Not only does the public not know where the nearest AED is, but 911 doesn't know where it is either in the vast majority of cases. Some estimates are that for all the AEDs in the nation, fewer than 1 in 10 exist in a database. And then even if they're in a database, do we know that the battery is valid, the pad status is valid, or importantly, where exactly is it and is it accessible? And because the systems engineering linking all the parts of this system needs immediate focus and attention, you know, we have situations like this.
Wow.
So we built our rescue project to really bridge that gap. It's one of those projects that was built around a solution to a problem. How can we capture the AED location, validate its location, accessibility and functionality, and then deploy that AED location information in a functional manner? So we have a bunch of tools to make that happen, and we're currently piloting all of those tools right now. Our app is actually findable for pilot testing in the Android and Apple stores. And there's a web form also that you can use, and we're currently testing our back-end database. And we're actually in the process now of releasing also a tweet bot. So the module that we're actually looking at right at the moment is the tool for AED, just to actually augment the database, to find the AED and enter it into the database. And you too can go and do that as we pilot it. We'll be piloting it probably for, we're looking at about 6 months. And, and we're also trying to transition it also into Israel right now. We also have a web form because a lot of people don't want to do this with an app. They want to be able to capture the data directly with a web form. So we have a QR coded web form and no app required. And we actually printed that web form on a t-shirt, so the t-shirt became a data entry tool, which got us a lot of attention. And you can tweet or DM to @AEDfound, and the defibrillators that you add there will be added into our database. You know, accuracy is really important, location, peripherals, accessibility, and data granularity, walking, running, driving, vertical distance to the nearest AED. You know, people like finding things, both high-tech and low-tech. Geocaching is the old low-tech way that people go around looking for things, scavenger hunts, Foursquare, Pinterest, Google Places. Pokemon Go is a classic example. And we've had some real interest now from the citizen science movement and the crowdinthecloud.org. Sort of like Pokemon Go for the AED. So we have a number of dissemination pathways, API feed to 911, big data mapping, and local data to apps. What's really important to us is that as we build this out, that it's scalable, translatable, and sustainable. And sure, Google Places, yes, add AED. So just by taking a photo of an AED with a phone or a camera, you could potentially be saving a life, because that AED could be found and used in an emergency and be the reason someone is alive today. So
Dr. Levick, thank you for sharing about that. Again, we're talking about innovation. Here's a perfect example of innovation. Now, is this data accessible to 911 centers, or is the database available?
At the moment, we're building it out and validating it.
Okay. So the best thing people could do is try the app, try the data entry tool.
Try the data. Yeah, we want to, until we can get the data entry modalities firmed up, we're not going to be deploying it, and we're going to be doing some pilots. As I say, the initial pilot was has been submitted to the NIH, and we feel it's very important to do proper evaluation of the system, its validation, and its deployment. And I've just now moved to Israel. We're very lucky. The city I live in not only is 16 miles from Gaza and we have a bomb-proof hospital, but our mayor is a doctor. So we're actually looking at, because it's a 250,000 population here, looking at an initial deployment here. And Israel's one of those, you know, sort of innovation hubs, and we look to being able to do some pilot work here as well. We've also spoken with the folks in Dubai. So there's a lot of scope for spending the next sort of 12 months or so getting this system fine-tuned. Clearly, there will be, new technologies, and we're very interested in looking at some of those. And in 10 years' time, probably your smartphone will be a defibrillator. But
right.
at the moment, it isn't. I think 1,000 people a day in the United States is just, you've got to do something. So we've been very grateful to the American Heart Association. We were the recipient of one of their innovation awards, and it really has been amazing, the support we've had for this. It's sort of a bit like that. The little spaceship going to the moon's been an incredibly low budget project that has really been able to harness some of the cutting edge technologies. And so really looking forwards to the next steps in this project here.
Well, great. Well, again, Dr. Nadine Levick, thank you for joining us at the EMS Leadership Summit and sharing your expertise and your innovations and your background. We do appreciate it. So thanks again.
Great chatting with you guys, and looking forwards to doing what we can do to move to the next stage in innovation.